Can I have the slides, please? Yeah, good morning. Thank you. Thanks to the college and the organizers and Amila for inviting me. So I'm going to talk about retinal surgery in uveitis. Do I go forward? Okay, so uveitis is a medical condition. So why vitrectomy? Well, retinal surgery has been involved with uveitis for a long time. We do it for three principal reasons. One is as a diagnostic vitrectomy, and then to treat complications that may be associated with the structural problems that come after a patient has uveitis, or as a standalone therapeutic uveitis. Now, vitrectomy or retinal surgery is principally used in pars planitis, posterior uveitis, and panuveitis. Now, when managing uveitis, usually a good history, clinical examination, laboratory and radiological examination, like what Dr. Mirna explained, is the mainstay of what we do. And afterwards, appropriate treatment is considered. Diagnostic vitrectomy is indicated if you have a problem in the clinical history, clinical presentation, or you have an inconclusive diagnostic workup. Or if after a diagnosis you start treating and the condition is either worsening or not responding, you'd like to do a diagnostic vitrectomy to detect undiagnosed infections or a masquerade syndrome where you might be missing a important malignancy. So therapeutic retinal surgery is where you can either extend the diagnostic retinal surgery or treat it where you can use it. It can be considered as part of surgery where you look after the complications, or it can be a standalone retinal surgery as well. So apologies for the crowded slide, but here you give a lot of etiologies for therapeutic uveitis. So if you look at the commonest indications, you will have the non-infective causes of Behçet's or juvenile idiopathic arthritis associated uveitis, and infective causes are the infectious endophthalmitis or acute retinal necrosis and toxoplasmosis. Standalone retinal surgery is when you consider a standalone retinal surgery is when you have inadequate response to treatment, or if your vitreous is having a dense opacity and you can't visualize the retina, or as we previously discussed, sight-threatening intraocular inflammation. When you consider retinal surgery, obviously there are places where we would not like to go. If the view is bad, we would like to either postpone or delay the surgery. So corneal or lens opacities is not a good condition to have when you are going into the posterior segment. If you have pre-existing hypotony, that means the ciliary body is shutting down, and that is not a good time to go in as well. But if the ciliary body shutdown is because of ciliary membranes, then of course we can consider surgery to remove the ciliary membranes. That will help with the reactivation of the ciliary body and the increase in the pressure. Pediatric uveitis, again, retinal surgery in children is not a easy surgery as well, and the risk of developing anterior vitreous membranes is high. So unless the patient is having a high risk of amblyopia due to a dense vitreous opacity, we would not consider. So how does it work? The direct anti-inflammatory effect is of benefit, that has been proven. You remove the vitreous depot of the pro-inflammatory cells as well as the other immunogenic antigens. Then there is better penetration of the anti-inflammatory drugs that we are administering. The oxygenation of the retinal tissue is elevated because the vitreous is taken off, and there's evidence to show that there is reduced reactivation of the secondary immune response. You also have the indirect advantages where you remove the debris and the floaters from the vitreous. You are able to remove any tractional elements. The faster resolution of macular edema is also demonstrated in certain studies, and there is a qualitative and a quantitative improvement in the vision. So if you are looking at the studies available, most of the studies demonstrate that there is almost 2/3 of an improvement in the visual acuity. So that means 1/3 of the patients do not have an improvement in visual acuity, and actually 1/6 of the patients do worse off than where they started. So this has to be kept in mind. Only 2/3 have a significant improvement in the vision. Majority of the studies do show that the macular edema also gets better. But this is confounding because majority of these patients are already on steroids, so there is a so this is a multifactorial thing. So we can definitely say that it is the retinal surgery that caused it. There's definite evidence to show that the immunomodulatory therapy, that means like oral steroids or immunosuppressive medication, is reduced. The amount that needs to be used or initiated is reduced if you have done surgery. Over the last 20 years, if you have looked at the randomized prospective studies, there's hardly any, actually only 3, and all these have very limited numbers. The numbers are very small, and they also give confounding evidence. So Tranos and his colleague showed that there is an improvement in the visual acuity and the cystoid macular edema following surgery, but again the number is about 23. This is comparing to immunosuppressive therapy. Quenos and his colleagues also did a study, and they also showed that the vision and the anterior segment and the posterior segment inflammation goes down, but still there was no statistically significant evidence. Shalaby and his colleagues, also very small number of patients in a prospective study, they demonstrated that the visual acuity actually improves, but they found that the cystoid macular edema did not improve and was better improved with the immunomodulation. So small studies when it comes to prospective analysis, and they are also giving a bit of a confusing picture. The recent study done for chorioretinal inflammation at L.B. Prasad Eye Institute has shown that there is benefit of retinal surgery in chorioretinal inflammation. They have studied 36 patients who had bilateral TB uveitis, who are already currently on treatment, and one eye they did retinal vitrectomy, and these patients after 1 month actually did very much better. So almost 3/4 of these patients showed a complete resolution of the chorioretinal lesions after on the eye that was having the surgery, and that eye actually had better vision as well after 1 month. So there was some benefit seen there. So that's the good side of the retinal surgery. How about the problems? All of the studies demonstrate that there is a progression of cataract, development of postoperative hypotony, the risk of iatrogenic tears and detachment is there, and there is a significant number of patients who showed elevated IOP after the surgery, and in the not only reduction of cystoid macular edema, some studies actually showed that 1/4 of the patient developed macular edema after the surgery, despite not having macular edema in the first place. So that's the evidence. So what do we do as retinal surgeons? If we look at our patients, you do the pre-op assessment. The uveitis specialist would be doing most of the time, but if you're planning for surgery, you need to do a thorough structural assessment, examination, IOP, ultrasound scan is probably mandatory, even if you have a clear vitreous. Sometimes more detail can be gathered with the ultrasound. Gonioscopy can be done because it will give you an idea of what will happen after the surgery as well. So these couple of slides are for the retinal surgeon, trainees who are here. What we do when what you should pay attention when you are doing a retinal surgery in a uveitis patient. So few things: surgical entry, obviously. You need to do the smaller gauge vitrectomies. 23 and 25 is advisable. 27, the smaller gauge, the smallest gauge vitrectomies are not advisable because the cutters will get blocked. We are reusing the trocars, but better to use a very sharp trocar or a new trocar when you are going in, because the inflamed pars plana can detach from the sclera when you are going in. So make sure that you go in directly, and make sure that before you turn the infusion on, that you are actually inside the vitreous cavity. So you press on the trocar and make sure that your the trocar tip or the port tip is visible before you turn the infusion on. How do you manage your vitreous? High cut rates, obviously, 5 to 10,000 cuts per minute, and low suction. Don't go beyond 3,000. Because the posterior vitreous is already detached in most of these patients, you don't need to remove it altogether. And you have to try to do a base dissection as much as possible, but be careful. One important thing is, after the vitrectomy, do a couple of fluid exchanges, because that really cleans up the whole vitreous. It's like washing the complete retina and the inside of the eye. So do a couple of fluid exchanges that clears up the vitreous, and the visibility becomes a lot more. Obviously, if you find anything else, make sure you document it and treat it. So retinal breaks, membranes, traction, you might need to do laser and apply tamponade as well. Surgical closure also very important, because of the inflamed sclera is very, does not close well. Have a low threshold for suturing the ports, and you can consider a partial fluid exchange at the end as well, but obviously gas or air inside prevents you from having a good look at the retina the following day. And periocular or intraocular steroids you can give at your choice, depending on how the condition is. Obviously, these can be infective cases, so you discuss with your uveitis specialist and the other team, and you plan the surgery. You don't want an infective case at the beginning of your list. Make sure that it's at the end of the list, or you have it in a different theater, and make sure that if it's an infective case, we reuse our cutters. Sometimes you will need to discard these cutters. Make sure that you tell the staff to discard the cutters if it's an infective case that you have handled. So after the surgery, obviously, you have to augment the steroids, the topical and the oral steroids. And once the surgery is done, don't just take over that patient as your own patient. This is a uveitis patient. The condition is still going on. You look after the post-op management, but always liaise with the uveitis specialist and the principal physician who has been managing, because that medication needs to be continued. So with that, I'm just going to come to the last slide. These are the things that I want you to remember when you are going home. Vitrectomy has improved, our instrumentation has improved, our techniques have improved, so it's playing a larger role in uveitis patients. There is evidence to show that visual acuity, recovery, as well as the lower usage of immunosuppressive medication is there, but because there's lack of prospective evidence, we can't at the moment develop universal protocols for surgery. You have to consider that the challenging surgical and the possibility of complications are significant, so a senior person would be better off doing these cases. You have to always communicate with the uveitis specialist, that means Mirna in our case. I hope you train someone else as well. And then the other specialists like the microbiologist, immunologist, rheumatologist that may need to contribute to the management. And you have to think whether the surgery is the option or not, and the timing of the surgery is also very important. Finally, we should never underestimate the complications of retinal surgery. Sometimes it can be devastating, and we have to always consider that when taking on that step, and because we do not want to have the patient at a position where they were worse off than at the beginning. Thank you very much.